Welcome everyone to the Solve MECFS Initiative's webinar series. Today we are thrilled to have Dr. Lucinda Bateman with us today. She leads the Fatigue Consultation Clinic. She's the founder of that in, correct me, Salt Lake, correct?
That's right.
Excellent. And she, as many of you I'm sure know, she is just a leading MECFS expert and beloved by many, many patients. So we are so thrilled to have you here today, Dr. Bateman, talking to us today about can MECFS and fibromyalgia research help you sleep? So take it away.
Thank you very much. I appreciate the chance to come share some of the interesting things I've learned in the last few months. Sleep has always been an important part of what we try to do clinically. And in the last few years, I've had some extra time to research sleep. I helped write an educational program that's on the CDC website that gave me a chance to dig into the topic. And those of you who know my practice style know that we treat the four legs of the table, and sleep is one of those very important legs. And I have to say, in the last 20 years, I have tried everything that is possible to help my patients sleep. So with that in mind, I'm going to talk to you a little bit about the things I've learned. What can be done? We know that sleep is a major issue, and I'll say that at the core of treating sleep is that you need to understand what the source of your own sleep disruptions might be, one or several things. And we know that some medications may disrupt sleep architecture or even cause primary sleep disorders. So things like stimulants and decongestants, some of the medicines we take that are important, like antidepressants, opioids and benzodiazepines can suppress the drive to sleep. And sometimes drugs that affect other neurotransmitters can change the pattern of our sleep, and certainly taking too many medicines. Sometimes we just think, oh, if we can just get to sleep, but too many drugs can sometimes disrupt the quality of sleep and really change what sleep does. We also know that treatable comorbid conditions that contribute to fatigue and sleep disturbances are a great place to aim. And we don't often think of this. Sometimes we just think, take something that'll make you sleepy at night. But if it's pain that's keeping you awake, if it's racing thoughts, if it's getting up to go to the bathroom multiple times, if it's someone in the room making a lot of noise, all of those things should be addressed, and they can help with sleep quality. And then, of course, there are primary sleep disorders. These are diseases of sleep that you would go to a sleep specialist to address, like obstructive sleep apnea or movement disorders, narcolepsy. So these are the things that we are fairly familiar with. But what I want to share with you today is some of what I've learned in the last year. I've had the opportunity to review hundreds of papers in the evidence base and research regarding MECFS. And because I'm interested in sleep, I wanted to take from those published papers some of the principles that might help us be more targeted for sleep in our specific disorder. So through my talk, if you see yellow print is a statement that is a fact from the research. And then usually I'll try to put the reference, and at the end of the talk we'll have a reference list if anybody wants to track down some of these papers. So in general, the literature tells us that sleep disturbances are extremely common across the diagnoses we're discussing. In fact, in each of the case definitions, regardless of which one you espouse or which one is used, CFS, MECFS, ME, fibromyalgia, all of those case definitions include something about sleep, unrefreshing sleep, or the nature of sleep as being part of the disorder. So it's part of the definition of these disorders is around sleep. The literature also tells us that sleep is abnormal in many ways. The quality of sleep, light, restless, interrupted, heavy, and also the timing or the duration of sleep can be affected or be abnormal, whether it's delayed onset or prolonged sleeping or irregular timing of sleep. All of these things can be seen across the population of people who meet our criteria. So I'm going to dig into the research in these 4 areas and tell you some facts that I think relate to sleep. We're going to talk about research using sleep studies to try to understand MECFS, and we draw a little bit from the fibromyalgia research. Research about central sensitivity and sensory amplification, hyperalgesia. This is very classic for the symptoms of fibromyalgia, that pain and sensation are increased. It's like the amplifiers turned up. And many people who are very ill with MECFS also have this kind of severe central sensitivity. So we'll look in that area. We're also going to look at what we've learned in research about the autonomic nervous system. And last, we're going to talk briefly about what published papers in our disorder tell us about the HPA-axis. That's the hypothalamus pituitary adrenal connection. So let's start with what we've learned from polysomnography studies, sleep studies. Well, for one thing, polysomnography is used to diagnose primary sleep disorders, and they are very common across the MECFS and fibromyalgia spectrum. So central sleep apnea, obstructive sleep apnea, restless legs, myoclonus, all of those are common. They're considered a separate disorder with overlap. But the real question, and so of course people should have polysomnography just to exclude or treat those kind of primary sleep disorders, because you probably won't feel as well as you can if a primary sleep disorder goes untreated. But really the question is there another intrinsic problem with sleep that's different than primary sleep disorders? And actually, as you see the print turning yellow, what we've learned is that polysomnography is not, you are not able to make a diagnosis of MECFS or fibro based on polysomnography. But there are things that have been shown in the research that are present in MECFS that are separate from primary sleep disorders. And this is very interesting because it starts to get at the pathology of disease. So studies show delayed sleep onset, fragmented sleep, increased alpha sleep, that's dozing or very light sleep, so much of the night people sleep too lightly. And also there's decreased delta sleep, that's deep sleep or slow wave sleep. And I just put this on here to demonstrate a little bit. The more awake you are, the more fine and tiny the waves are. So these on top are the awake waves. These are alpha waves, the second line with the big yellow star. And that's really drowsiness. But people with MECFS and fibro have a lot of alpha waves during sleep. That means a part of their brain during sleep is actually not really asleep, it's only drowsy. And then if you look down to the bottom, these where the second star is, this is slow wave sleep, stage 3 and stage 4 sleep. And people with MECFS and fibromyalgia don't have enough slow wave stage 3 and stage 4 sleep. So this has been, I think in some ways for someone like a patient and someone like me, a clinician, it's sort of like, yeah, we've known this a long time. But it's really important that these papers from the evidence base become part of the general knowledge of our illness. So polysomnography can tell us about primary sleep disorders, but so far not much about what primarily disturbs MECFS sleep. Why is the sleep fragmented? Why don't we get into deep sleep? And why is there intrusion of alpha waves and those things that we heard? Well, we're not sure, but it's possible that the other areas of research will help us learn about what some of the factors are. So we're going to talk about the second area of research, and that's research around central sensitivity. That's the sensitivity of your nervous system. And we know that pain amplification and hyperalgesia, that means increased pain, is present in fibromyalgia. And the research shows that alpha waves are present in sleep when pain is there. So maybe pain is one of the contributors to alpha waves. And I think there are probably other things that can show that as well. And that's been in the literature for a long time. And although we've thought about fibromyalgia as being the disorder of central sensitivity, we know that sensory amplification is present. in MECFS because noise, bright light, temperature extremes, all of those things are part of central sensitivity. And that feeling of central overload is part of post-exertional malaise. And if you think about when you push into post-exertional malaise, you can feel tired but still wired or too exhausted to sleep. And I have one patient who describes it as over-signaling. So when he's in post-exertional malaise, he's signaling so much that it's almost like there's an electrical current plugged in that makes it very difficult to relax and to sleep, even though it's a state of exhaustion. So this is central sensitivity. So if central sensitivity is present, how can we take that knowledge of physiology and apply it to helping sleep? So first of all, you can prevent that over-signaling by pacing. Don't get yourself in a place of post-exertional malaise. Try to avoid that. Stop short of that. So when night comes, you won't be so wired and over-signaling that it becomes difficult to sleep. This is why you want to have wind down before sleep. Have quiet, dark, good temperatures. Create an environment that will help the central sensitivity down-regulate and reduce all kinds of activation. So, looking at a computer screen or watching TV activates your brain. So it might not be a good idea to increase activation in a sensitive brain approaching night. So if you know you have a lot of central sensitivity, it would be good to avoid those things. What kind of medications might work in a state of central sensitivity? Well, this is where medications like gabapentin or Lyrica, other anticonvulsants, calm the central nervous system. This is where low-dose naltrexone, which is an up-and-coming therapy, might be helpful. It calms inflammation in the brain. It calms glial cells that are activated. We sometimes use drugs like clonazepam, which is a benzodiazepine. This type of medicine calms central sensitivity. But it might be, this kind of drug has a habituating nature. It's very long-acting, and sometimes the sedation or the calming of your brain lingers into the day, which might cause more fatigue or brain fog. So these medications have to be chosen carefully and used in very low doses and individualized to each person's case. And we're all familiar with drugs like very low-dose amitriptyline or doxepin and cyclobenzaprine to calm central sensitivity, to reduce pain, and to anything that is activated and kind of wired can sometimes be calmed down by those medications. So knowing your own degree of central sensitivity might help you choose the right kind of medication to help assist with how that interferes with sleep. Okay, third on the list in the area of research is the autonomic nervous system. We actually know quite a bit about the role of the autonomic nervous system in MECFS and fibromyalgia. And all of the studies point to a dominance of the sympathetic nervous system over its balancing side, the parasympathetic. Now these are the two arms of the autonomic nervous system, and I'm going to focus a little bit on the sympathetic side because that's the part that seems to be a bit overbalanced in our disorders. So there's more input from the sympathetic or not enough input from the parasympathetic to keep it balanced. The signaling in the sympathetic nervous system is mainly adrenaline, and the other name for that is epinephrine. And the other neurotransmitter is, it has two names also, noradrenaline or norepinephrine. And you may have heard that term norepinephrine because that is a neurotransmitter that plays a role in pain. And it's like Cymbalta and Savella have norepinephrine, they help increase norepinephrine levels. So if there's sympathetic overload, that means that you've got more production of epinephrine and norepinephrine. And adrenaline or epinephrine comes from your adrenal gland, and the norepinephrine is released by sympathetic neurons, and and at the alpha and beta receptors that are spread throughout your body. So it's ubiquitous throughout your whole body. And if there's an overload on the sympathetic side, it results in increased heart rate. And in the research, in addition to increased heart rate, there's a way in science we use what's called heart rate variability. And that's how fast and regular your heartbeat is. And the more that you produce epinephrine and norepinephrine, the faster and more regular your heartbeat gets. It's less variable. So we can measure heart rate during sleep and see that not only is it faster than it should be, but it has that lack of normal variability. So when you're really relaxed, your heart rate goes up and down, and it changes with your breathing. And when you're not relaxed, it's boom, 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 and it's very regular, like it's being driven. And this indicates increased sympathetic tone, sort of like the sympathetic nervous system is on low instead of turning off, and then decreased tone from your vagal nerve, which is the parasympathetic side. And we have learned in the research that this is present across the board. Well, imagine what that might do to your sleep. If you're trying to go to sleep and you've got increased sympathetic tone and have that adrenaline floating around in your body, it's going to be more difficult to get to sleep and more difficult to stay asleep. So if you have this sympathetic greater than parasympathetic tone, then what you want to do to sleep is to change that balance. We want to boost up the parasympathetic side of your autonomic nervous system so it's even higher than your sympathetic. We think of this as the sympathetic is your fight and flight side of the autonomic nervous system. So the opposite, the parasympathetic, is the relax and digest your food and all the things you do when you're resting and recovering. So how could you shift from sympathetic to parasympathetic? Well, guess what? That's why we teach people to do slow, deep breaths and a long, delayed exhalation when we're doing yoga or relaxation exercises. When you take slow breaths and have a long, prolonged exhalation, it actually releases chemicals from your parasympathetic nervous system, and it becomes more active, and it starts to counterbalance the sympathetic. So deep breathing, pushing back thoughts of worries and stress, doing things to shut down your sympathetic nervous system and enhance your parasympathetic nervous system is going to be calming, and it's going to make it more possible to get to sleep. So we should all learn how to do these activities. If you're just run, your motor's going, and you wound tight, when you sit down to go to sleep, your sympathetic overdrive is going to be pronounced, and it's going to be very difficult to relax. So there are ways to do it like a yoga, like a monk doing meditation, actually lowering your heart rate and lowering your blood pressure with deep breathing and relaxation exercises. But I've also had success in some patients, particularly patients with POTS, postural orthostatic tachycardia syndrome. Those patients have a very strong sympathetic overdrive because they're trying to compensate for a low blood pressure, and there's a drive for very fast heart rate. And that adrenaline is probably floating around in excess in the body and makes it difficult to get to sleep, and which is why kids with POTS can't get to sleep. And then their nights get turned upside down because when their adrenaline levels finally disperse, then they get to sleep late, and then they can't get up in the morning because their sleep cycle starts to be shifted. So I've had some luck with very low dose propranolol, and in the evening, a couple of hours before bed, in people who have strong sympathetic overdrive. And those would be people, and you think about this, if you can feel your heart pounding in your chest when you lie down. You don't notice it so much when you're up and around. Lie down in your bed and try to sleep, and you can feel the hyperdynamic beating of your heart. Not necessarily fast, just beats hard. Or you have a few arrhythmias. Those are the manifestations of the sympathetic overdrive on the beta receptors in the heart. So if it's appropriate and your doctor thinks it's safe for you, you can block the sympathetic receptors with a beta beta blocker like propranolol or other similar medications. Might not be for everybody, but in some cases it might assist sleep. And I've taken some of my younger patients with POTS, and all we needed to do was sort of block the effect of adrenaline on their heart and their vasculature, and they're able to relax and go to sleep in the evenings. Now the fourth area of research I wanted to talk about is research into the HPA-axis, the hypothalamic pituitary adrenal axis. It's actually a little more complicated than that, and I'll tell you on the next slide. But what the published papers show in our disorders are that there is an attenuated or reduced cortisol production in the morning particularly. And there is normal circadian rhythms of the cortisol seem to be kind of flattened. So I'll show this on a picture in the next slide. The overall cortisol levels are normal, are lower than average. Not as low as someone who has adrenal insufficiency, but if you think about the average range, the average should be in the middle, the cortisol levels of MECFS patients fall in the lower quarter, below the average line. And the research has been, there's been a lot of research to see if the adrenals work, if the pituitary works, and surprisingly it seems like the adrenal glands and pituitary are probably normal, which leads us to wonder if there are upstream problems. So what is upstream from the pituitary is the hypothalamus. I'll talk a little more about the hypothalamus in a minute. So here's a diagram that shows normal cortisol secretion. Here is 6 a.m. and 9 a.m. You can see that the levels of cortisol in a normal person should rise and peak about the time we get up and get going in the morning. And then this is an average. Generally all day long they tend to fall down so that by bedtime this energizing cortisol is lower in your body and you can sleep. But the CFS research shows that this peak is lower and that this dip is higher, which means people wake up and don't have as much energy, and when they're getting ready to go to bed, they've got this energizing cortisol still in the blood. Down below in the purple and yellow, this is an actual graph. Each spot on there is a measurement of cortisol in a person, and you can see that it's up and down, it rises in the morning. It doesn't actually fall neatly till night because events cause cortisol production. So let's say right afternoon there's something, the person goes running or has some demand, and so up and down the cortisol is excreted to try to help with energy and metabolism and management of the inflammatory and inflammatory and immune system. But by night the levels finally calm down and come down, and that's more of a normal curve than this big average. So it's abnormal, right, in our patients, and we don't know for sure why this cyclic nature of cortisol seems to be less. There seems to be less signaling, and it might seem like, oh well, we can just take some hydrocortisone in the morning, and that would be an easy way to solve this problem. But it's not that simple. As you can see for this diagram, these blue pills are these hydrocortisone, which is the pill form of cortisol, which is the natural hormone in your body. These pills, if taken, they'll do just what cortisol does. It regulates glucose uptake and how you store fat and defend the body against infection, help the body respond to stress. It's not good not to have cortisol, but if you take it from the outside, it also is inhibitory. So it's in the blood, floating around, and guess what it does? It suppresses the normal function and the release of corticotropin-releasing hormone and ACTH. So if you take it from the outside, the signals from your hypothalamus and pituitary to your adrenal actually tell your adrenal to stop making cortisol. So that's the problem. You're taking pills from the outside, you actually atrophy your adrenal gland or cause problems with your own adrenal gland, which was normal before you started taking the hydrocortisone. So this is why we're a little concerned, and we'd like to understand why the problem is there rather than just immediately supplementing the hormone, which might cause long-term problems or even cause a new disease in the patient and make them dependent on the external administration of cortisol. So it's more about why is the body doing that? And it certainly is likely to be playing a role in why you don't feel well, don't deal with infection and immune stressors as well, and probably impacts sleep. So this is a little diagram trying to show the relationship between these areas. And the hypothalamus is up here, and I've made a little explosion there to say maybe the problem is in the hypothalamus. But the hypothalamus sends signals to the pituitary, which sends signals to all of the end organs out there. I put up here, instead of just HPA, we should really be saying HPA because of the signals to your adrenal, HPT, that's hypothalamus, pituitary, thyroid. HPG is the signals down to the gonads. That's where you make estrogen and progesterone, testosterone. And then there's a signal from the hypothalamus to the pituitary that doesn't have an end organ, and that's the production of vasopressin. That's a hormone that controls your fluids and your blood pressure. So it's very, very important loop. And you can see that if you had dysregulation of all those areas, that could produce something like chronic fatigue syndrome, MECFS or fibro. Well, the levels of those feed back to the hypothalamus and tell the hypothalamus how to respond. But even more than this cycle of feedback, your hypothalamus gets signals from your entire body. It is the control center of your brain. It senses hormones, electrolytes, and other elements of body chemistry. It senses temperature. It senses core temperature and skin temperature. It senses your blood pressure and tries to send messages to correct your blood pressure if it's too high or too low. It senses light, and it senses emotions. So if you're stressed or relaxed or having, feeling excited, all of these emotions feed back through neurons and centers in the hypothalamus that then send a signal to the pituitary, your thyroid, your adrenals. Or guess what? The hypothalamus also controls your autonomic nervous system. It sends signals to the sympathetic and parasympathetic system. It's starting to see how these are all highly interrelated systems. So we can hopefully learn to manipulate what's happening at the hypothalamus. Let's say hypothetically the problem is at the hypothalamus. We know that downstream are some very important neuroendocrine or endocrine organs. Are any of these controllable? Can we control our emotions? Can we control light? Can we do something to control blood pressure and regulate our skin temperature? Because abnormal signaling comes into the hypothalamus and causes signals to be sent. So how can we use that to help our sleep? Well, sounds a little bit like the advice we've been talking about with sleep. You want to relax, calm your emotions, and you want to have an environment to go to sleep that is quiet and dark, not too bright. If you're sending bright signals through the neurons into the hypothalamus, you're going to send a different message downstream. We try to nudge this and manipulate it. If you're orthostatic all day, you're standing up, your blood pressure's low, your heart is racing, you're going to get different signals than if you're compensating and treating your orthostatic intolerance and controlling your temperature the best you can. So you can use behavioral interventions to some degree to send more regular calming signals to the hypothalamus so that it will send the right hormones downstream that affect both your endocrine organs and your sympathetic overdrive. So it all starts to blend together. So, it's tempting to just drug ourselves with heavily sedating medicines, but we all know that that doesn't always result in feeling very well the next day, and it doesn't even result necessarily in perfect sleep. Bottom line is just taking a lot of medicines to sleep is really unlikely to cure the illness. Even using as many techniques as we can is not really curative. And I think that's sometimes why people try to take too many medicines. They're just sure if they can sleep that they'll be less tired the next day, and that's not necessarily true. But you want to achieve the most restful and restorative sleep you can, and do it in the most natural way possible by aiming at the underlying problem. It is true that better sleep reduces, now notice this isn't yellow, this is my opinion, but after many, many years of doing this, I'm convinced that better sleep reduces pain and it improves daytime somnolence. We know that's true from sleep studies. And I think people's well-being is better. I think almost all the symptoms are better if restorative sleep is achieved. But it isn't necessarily better just by forcing sleep with a strong hypnotic medicine. The other thing is that sleep disturbances are within our grasp. This is one of the parts of this horribly disabling and elusive illness that we can work on. It is one of the more treatable aspects of illness. It might be hard to change the unrefreshing nature of sleep. It may never be completely refreshing. I think people think that if a sleep is refreshing, you're not tired the next day. And this is an illness of fatigue and multi-system illness, so I don't think we can count on sleep to necessarily be totally refreshing, but it would be great if sleep was as good as it could and you could get rested from the previous day's activity, and as many of the processes that should occur while asleep do occur, because the brain is complicated and it needs that time for all of those areas to restore themselves. We honestly don't have studies that tell us that treating sleep with medications provides benefit for the illness other than what I described. We don't know if it changes prognosis. We don't know if it makes things worse down the road. So those are the things that we need a lot more research in, and we just haven't had enough treatment trials in this illness yet, period. So I just wanted to throw out some concepts at the very end here, and that is it's good to distinguish between being sleepy and being tired. And when we say sleepy, I mean the term somnolence and sleepiness, or the need to sleep during the day. Like you sit down and fall asleep, or you get in a warm room and you immediately fall asleep. Sleepiness is a little different than illness, tiredness, and fatigue. It's actually the more treatable part of the illness. So if you're sleepy, it's usually because you have poor sleep, right? You have sleep deprivation, or there are medications that are contributing to sleepiness, and you really should look at that. And there are a few illnesses that cause sleepiness, but most of it comes from disturbed sleep and sedating medicines. And I put on here the Epworth Sleepiness Scale. This is available everywhere. You can take it. It's really quick, few questions. And if you score high on the Epworth Sleepiness Scale, you really should work with your doctor and examine your sleep and make sure that you're not making yourself sleepy during the day in a way that's very, very treatable. Should be looked at. So in summary, I tried to pack all the recommendations real practical on one slide. These are kind of the practical things that come out of all this science, and they start to sound familiar, but they're based now in mechanisms that we know are present in our illness, and that's improve your sleep hygiene, try to go to sleep and create your own circadian rhythms, make your environment conducive to calming the autonomic nervous system and calming central sensitization. Try to do as much activity in the day as your illness permits, but don't do so much that you push into post-exertional malaise that's going to unravel your sleep by making you too wired and aggravating central sensitivity. In general, if you take a lot of naps during the day, that disrupts your cycles, and we just talked about sedating drugs. Do everything you can to aim at the cause of the sleep disruption. Don't just drug yourself to sleep. And simplify the medicines. Get really good, if you need a medicine, at targeting what needs to be targeted. Is it trouble getting to sleep? Then you might want something that is short and helps. You want to work on all the behavioral things, winding down, getting cyclic, and then being light but using drugs that are going to help you get to sleep. If it's light sleep all night, that alpha intrusion and frequent awakening, you want to do things to reduce those interruptions, and you're going to use a medicine in a low dose that's longer acting, and then we'll treat that problem. And then early morning awakening is a really different animal too. We think of this as being associated with depression, but also a lot of times my patients don't realize that their medicines are wearing off about 4 or 5 in the morning, and even medicines that they take during the day, and they're causing some kind of rebound or withdrawal, and changing the timing or the dose of those medicines is helpful. So all of these things, if you dig in and spend some time and do some research on your sleep, might be helpful. And certainly natural sleep without drugs is the best. It's how you get the most restorative sleep. But there's something intrinsically wrong, as we learned from polysomnography. I think it's because there's central mechanisms that are disrupted, and that means maybe it's going to be challenging. And if sleep is chronically disrupted or inadequate, I think it makes the illness worse. So you've got to find that balance. There's no perfect medicine. Almost all medicines have adverse effects. So your goal is to have a big project of working toward restorative sleep. So I just put this slide in to review. These were the areas of research we talked about that really have a promising base of evidence that we can build on to try to understand what the primary problems are with sleep through polysomnography or new techniques. We need to know more about central sensitivity and what's going on in the brain with all of this amplification, and see what we can do to calm it. We need to know more about the autonomic nervous system and do better at increasing the parasympathetic balance so that the sympathetic overdrive does not disrupt our sleep. And then we need to understand more about the HPA-axis and how we can, how our behaviors can help send the right signals to the hypothalamus. So that's the end of my talk, and I think what I'd like to do, if we can, maybe is field some questions. If
Absolutely. We actually have had several that have come in along the way. I'll grab a few of them. We had a few questions about diet, how that could affect sleep. Should they avoid carbs at night? Any specific dietary issues that they should be considered with?
So that's a good question. Aside from caffeine and those kind of things in diet, I think carbs can go both ways. Some people feel that if they eat a few carbs, it makes them sleepy, and other people develop reactive hypoglycemia from eating too many carbs, and then they wake up with activation and hypoglycemic symptoms. So you kind of need to gauge your own body and know how you respond to carbs. Milk products sometimes help people sleep, and there are other things. I think a heavy meal, and I eat a big meat. If I eat a huge steak, I thrash all night long. So I think it's generally better not to have heavy meals near bed. You really don't want your body working on anything when it's time to sleep. You don't want it working, you don't want your mind working, you don't want your GI system having to do a lot of work. Really, you ought to put your whole body to rest and give it a chance to have all of the input quieted down when you're ready to lie down and sleep.
Great. We have received several questions about melatonin and your thoughts on using that.
Melatonin is, a hormone produced by your pineal gland, and it responds to day-night cycles. So first I want to talk about real melatonin, right? So when people start having upside down and they don't ever get outside, they don't get sunlight, their brain probably becomes kind of confused about day-night cycles, which is why even though you're really ill, you want to try to have light exposure and dark at the normal times as much as you can. Melatonin as a supplement helps to resend that signal, that cyclic signal back to the body and the brain, and I think it works the best not used all the time. This is like all medicines. I think what we'd like is for your own natural melatonin to work, but if those cycles are off, one of the ways to get the cycles back on track is to use melatonin to kind of reset those circadian rhythms. But anything, bad illness or kind of dysfunctional behaviors can blow right through a signal like that, so it can be helpful. It's pretty safe.
Okay. We also have received a few questions about the use of supplements, and if those can have any effect on your sleep. There weren't specific ones listed, but just a few questions about your thoughts on supplements.
Well, I guess it's too broad of a question
That's
to
what I
answer.
thought. Yeah.
Supplements in general, I look at like medications. They're chemicals and medications, so in the right amounts when you need them, they can be very, very helpful. In excessive amounts, they could cause problems. I mean, I know people get reflux from their or they get nausea from putting, supplements in their stomach without food. So there are, I mean, I like herbal teas that, nudge you towards sleep. And so supplements that are meant to help you relax and prepare for sleep, I think they're great. If they work and work for you, then I think in the right amount and they're gentle, then I think it's great.
Okay, and here's another one, different topic. Wondering if autoimmune dysfunction can cause any of the problems in the HPA-axis that you described? Any thoughts on that?
I think that we don't know yet why there's disruption in the brain, but I think we're pretty excited about new studies that show neuroinflammation, which is sort of the central nervous system equivalent of autoimmune. But boy, that's an area of medicine where we're just starting to understand. I think about other illnesses that are characterized by neuroimmune degeneration, like multiple sclerosis and Parkinson's and Alzheimer's, and some of the diseases that are in the brain related to neuroinflammation we don't understand very well. We're just barely on the edge of our knowledge. So we have to have a little bit of graded expectations to understand an illness that might be something totally new, like MECFS and fibromyalgia, but still involve different neuroimmune mechanisms, which are like autoimmune. So I do think that the field of neuroimmunity and autoimmunity is going to be very, very important, and I think it probably does play a role. And then also, I'll just go back to the POTS example. Adolescents with POTS, I think many of them have an autoimmune disease that attacks their alpha and beta receptors to create their POTS. And there's a study published this year that showed that autoimmune POTS, that the very first test to identify the specific antibodies that bind to alpha receptors and beta receptors are present. Now, that hasn't been replicated yet, but I thought it was super exciting because the antibodies bound to alpha receptors are the ones that make the blood pressure drop, and the antibodies in this little study that went to beta receptors were the ones that made the heart race even more. And theoretically, we should be able to develop tests to measure them, and we have a lot of drugs that we might be able to use to block the effect of these antibodies, and eventually maybe some kind of immune therapy to prevent the formation of antibodies. Or if we could track it back to the inciting viral infection, maybe we could prevent it all from happening. So I think it's very promising, and autoimmunity is one of our most promising fields.
Right. Well,
could I add one more thing?
Please do. Please do.
If you want to soften an autoimmune disease or prevent autoimmune disease, guess what you do? You get more sleep, you pace, you have healthy life. So it's all part of what we're trying to do anyway. Yeah. It should help in that role.
Right. Lastly, we did have a few requests for your slides, and I'm wondering if it would be all right to make them available.
Sure.
Okay, great. So then I will let everyone know that we will do that.
And why don't you put the bibliography up there too so they can look up the papers?
Absolutely. I'll go to that right now. So we actually have 3 pages here of the bibliography. So I will share the slides in their entirety. So all of this will be here as well, and I'll just quickly scroll through them so you can see. These are all of the papers that were referenced in the talk. So we will make this information available when we make the slides available as well. So we'll get this posted to our website shortly. I'm going to go ahead and wrap it up today. I just want to thank everyone so much for their time today. Again, we do have one more webinar left in the series in December, on December 16th. Carol Head and Dr. Suzanne Vernon are going to bring a research summary, sort of a lot of the highlights of what's happened in the last year or two, the last few years, exciting research to all in one webinar. So please plan to join us for that one. That will be on December 16th. Of course, you can sign up for our Research First e-newsletter that comes out once a month, with lots of information, particularly on the research front. You can like us on Facebook and stay connected that way. And also you can look into joining the biobank if you haven't already, and that's a way to be involved in research sort of from the comfort of your own home by being enrolled in the biobank, and the information there is on the screen of how you can register to be a part of that. And of course, if you like the work of the Solve MECFS Initiative, particularly at this time of the year as we wrap up our fiscal year, any donation helps continue and further our work. But most importantly, I want to thank you, Dr. Bateman. If we didn't have everyone in silence, I'm sure that you would hear a rousing round of applause, because I could tell from the comments that it was a very clear talk. People got a lot out of it, and so we really appreciate not just what you've brought us today, but what you do every day, you know, for all of the patients that you treat and those that are positively affected by your work. So thanks to everyone for being here today. We appreciate your time very much.